Today we will be discussing about the biomechanics and kinesiology of the knee joint. All of you know the biomechanics, the term biomechanics consists of two terms actually. It is kinetics and kinematics. Kinematics means regarding the movements happening in a joint, and kinetics means the causes of that movement, the forces. There are two types of forces can make a movement. It may be an external force or an internal force. External force means the force outside the body. It can be either given manually or mechanically. But at the same time, internal force means these are the forces inside the body which cause movement. So the internal force is mainly done by the muscles itself. So today we'll go through the different muscles which causes the forces, and along with that we'll go through different movements, that is kinetics of the knee joint. First of all, we'll go through what are the importance of knee joint. Knee joint is one of the largest joint complex in the body, and any joint, like any joint, it's having both mobility and stability functions. So usually a mobility function of a joint always compromises the stability. Once we take the example of a shoulder joint, the mobility, it is a joint which is having lots of mobility. So it compromises the stability. That is, a shoulder joint is a joint where stability is less and mobility is more. But at the same time, knee joint is a joint where it is having both stability and mobility, and it is one of the largest joint complex of the body. Now, like any other joint, it's having a proximal articulation and a distal articulation. A knee joint is a joint which is having three joints, that is two different types of joints inside a single joint capsule. That is two distinct type of articulation in a single joint capsule. That is two tibiofemoral joints and one patellofemoral joint consist of knee joint. Now, regarding we'll just go through regarding the tibiofemoral joint. That is the tibiofemoral joint is the joint formed between tibia and femur, and it's a double condyloid joint which is having 3 degrees of freedom. The term degree of freedom means in how many planes a joint can be moved, and knee joint, tibiofemoral joint is a joint which is having 3 degrees of freedom. And some of the researchers are saying that we can say tibiofemoral joint is having only 2 degrees of freedom, but most of the researchers are saying that the tibiofemoral joint is having 3 degrees of freedom. The difference is that the first movement available is the flexion and extension of the knee joint. You can see in the slides the flexion and extension movement of the knee joint. That is, it is occurring in the sagittal plane. The second movement is the medial and lateral rotation of the knee joint. It is occur in the transverse plane. You can see the second movement here. This is the internal rotation or medial rotation and external rotation or lateral rotation of the knee joint. And the third movement is the abduction and adduction. This movement cannot be done actively, and this can be done passively, and very mild abduction and adduction movement is possible in the knee joint. That is, there are 2 ligaments on the both sides of the knee joint, that is medial collateral ligament and lateral collateral ligament. These ligaments restrict the adduction and abduction movement, and this abduction and adduction movement can be done passively. But in case of any injuries of the lateral side or the medial side, which causes more movement of abduction and adduction, more abduction and adduction movement will be available in the case of any injury to the medial and lateral side. Now, we discussed the tibiofemoral joint. It's a double condyloid joint of 3 degrees of freedom, and it's having, any joint will be having a proximal articular surface and the distal articular surface. The proximal articular surface of the joint, the tibiofemoral joint, is formed by the lower side of the femur, that is medial and lateral condyles of the distal femur makes the proximal articular surface. So the two condyles are there. The first one is a medial condyle and the second one is a lateral condyle, and the two condyles are separated by an intercondylar notch. That is the proximal articular surface of the knee joint. Second one is the distal articular surface. Distal articular surface is the upper surface of the tibia. So there is medial and lateral tibial plates are there, or condyles are there, and here the two plates or two condyles are separated by an intercondylar tubercle. Instead of in the notch in the femur side, here there is intercondylar tubercle on the tibial side. Now there are these condyles or these plates are asymmetrical in nature. That is, the medial side, you can see in the picture itself, the medial side is larger in antero-posterior direction. It's having its own biomechanical importance. We'll come to that portion later. Now, regarding the anatomical and mechanical axis of tibiofemoral joint. We can see we have a wider pelvis and a narrow knee. So, the anatomical axis of the femur, it is oblique. Anatomical axis of the femur, it is not straight, it is oblique. It is oblique, directed inferiorly and medially. The anatomical axis of femur is oblique, directed inferiorly and medially. At the same time, the anatomical axis of tibia is almost straight. So, anatomical axis of femur is oblique and the anatomical axis of tibia is straight. So, what will happen? One is oblique and other part is straight. So, it forms an angle on the medial side of the femur or medial side of the knee. So, this is a normal one. Anatomical axis of the femur is oblique, directed inferiorly and medially from proximal to the distal end. At the same time, anatomical axis of tibia is almost vertical. So, these two anatomical axes, that is anatomical axis of the femur and anatomical axis of the tibia, forms an angle. It is a physiological type of angle and the angle is around 180 to 185 degree, and this is known as physiological valgus of the knee. This is physiological and it is normal. This is known as physiological valgus of the knee. Now, there are you might have seen different peoples, it's having a different types of knee joint. That is means that its angle will be this physiological valgus. There will be variation in the valgus. So, if this angle, if the physiological, if it is more than 185 degree, the condition is called genu valgus or knock knee. If the medial tibiofemoral angle is greater than 185 degree, we can get a knock knee. This condition is called knock knee or genu valgus. And if it is less than 175 degree, if the tibiofemoral angle, medial tibiofemoral angle is less than 175 degree, we will get another condition called bow leg or genu varus. So, any biomechanical abnormality causes more pressure on different areas. For example, in case of medial, that is knock knee, it creates more pressure on the lateral side and later it leads to the osteoarthritis on that side, and in case of genu varus, bow leg, again it creates more pressure on the medial side, later leads to osteoarthritis changes on the medial side more. Now, next important structure around the knee joint is the joint capsule. All the joint will be having a joint capsule, and main function of the joint capsule is the restriction of the movement or the stability of the joint. And like any other joint, it is also having, the knee joint is also having a joint capsule, and this joint capsule, it's a large joint capsule, but it is lax. And the capsule is, this capsule encloses entire tibiofemoral and patellofemoral joint. Again, like any other capsule, this joint capsule is having two layers, a superficial layer and an inner layer. Superficial layer is a fibrous layer and inner layer is a synovial layer, and the synovial layer, inside the synovial layer there is synovial fluids which helps in the lubrication of the joint. Now inside the joint there are some C-shaped type of cartilages, fibrocartilages can be seen. This is known as meniscus, and this meniscus, it is C-shaped, and the this peripheral border is thick, and it is the peripheral border of the meniscus is thick and is attached to the capsule on the peripheral side. But at the same time, the inner border is thin and it is concave and forms the free edges, and the anterior and posterior edges of this meniscus is known as horns. Then the upper concave surface are in contact, the upper side concave surface of the meniscus are in contact with the femoral condyles, and the lower side is flat and it is attached with the tibial condyles. Now what are the functions of the meniscus? The first function is it deepens the articular surface, and the second function is it is having a cushioning effect, and it acts as a cushion between two bones and allows the and decrease the pressure or the bones. Then there are two meniscus. There is a medial meniscus and lateral meniscus. The medial meniscus, you can see the medial meniscus there. The shape of the meniscus is almost crescentic shape, and the next important thing regarding the medial meniscus is that this meniscus always moves along with the bones, and the medial meniscus is relatively immobile when compared to the lateral meniscus. So the medial meniscus is more liable to injury, or more chances of injury of the medial meniscus is there in the knee. At the same time, the lateral meniscus, it is rounded in shape. The anterior and posterior ends lie within the end of the medial meniscus, and posteriorly it is separated from the fibular collateral ligament by the tendon of the popliteus, and the lateral meniscus, because it is movable, so there is less chance of injury in case of lateral meniscus. Now usually the meniscal injuries, you might have seen lots of meniscal injuries, and it is commonly seen in footballers and cricketers, and the mechanism of injury is the medial meniscus is torn the 3 times than the lateral meniscus, and the mainly a rotation type of movement causes the injury. The injury is produced by the rotation of the femur on the tibia, or the reverse with the knee joint, partially flexed and carries the weight of the body. Then next important structure is the IT. IT band starts from the hip to the lateral, it passes through the lateral side and attached to the proximal end of the tibia. And as it is a lateral structure, the main function of this IT band is support the lateral side, and it resists the internal rotation of the tibia, and it maintains the integrity of the lateral side of the knee. Now once we see the movement of the IT band during the flexion and extension, during flexion the IT band moves backwards, and during extension the IT band moves forward. So what will happen is that the IT band gets always in touch with the lateral epicondyle of the femur. This causes a friction syndrome. There will be chances of pain and inflammation on that side of the IT band, and this condition is called IT band friction syndrome or iliotibial band friction syndrome, and it is commonly seen in runners, and especially in runners and other players also. Now another structure around the knee joint is bursa. Bursas are actually, these are fluid filled sacs which helps the muscles and tendon to move freely. There are lots of bursas around the knee joint, and the important bursas are, the first one is a prepatellar bursa, infrapatellar bursa, and suprapatellar bursa. Prepatellar bursa seen just in front of the patella, that is between the patella and skin, and infrapatellar bursa between the superior part of the tibia and patellar ligament, and suprapatellar bursa between the inferior part of the femur and deep surface of the quadriceps femoris muscle. Now, another important structure inside the knee joint is the cruciate ligament, and like the name implies, it's a cross-shaped ligament, or it's a cross-shaped ligaments, and these are the main bond between the tibia and the femur, and they cross each other within the joint cavity, and these are named anterior and posterior according to the attachment on the tibial, according to the attachment on the tibia. So there is an anterior cruciate ligament and there is a posterior cruciate ligament. We will go through what is an anterior cruciate ligament. Anterior cruciate ligament, it is attached to the anterior side of the tibia, that is anterior intercondylar area of the tibia. From the anterior intercondylar area, it goes upward, backward and laterally. It goes upward, backward and laterally, and it is attached to the posterior part of the medial surface of the lateral condyle. That is, the first ligament is the anterior cruciate ligament. It is the one of the main attachment, main contact between the tibia and the femur, and the tibial attachment on the anterior side, and that is anterior intercondylar area. From the anterior intercondylar area, it goes upward, backward and laterally. And the femoral attachment, it is attached to the posterior side of the femur. The main function of the ACL is prevention of the anterior displacement of the tibia on femur. So while walking and while extension movement of the knee, once this ACL, main function of ACL, it prevents the anterior displacement of the tibia. So in case of an ACL injury or torn ACL, the patient will come to you saying that I am feeling a giving away phenomenon. That phenomenon is called giving away phenomenon. The patient will feel his knee is, or his tibia is moving away from his leg, anterior to his leg. So the main function of the ACL is prevention of the anterior displacement of the tibia on femur. The next cruciate ligament is the posterior cruciate ligament, and as the name implies, it is attached to it's starting from the posterior intercondylar area or posterior side of the tibia, and it moves opposite to the ACL, that is, it goes upward, forward and medially. And the femoral attachment, the anterior part of the lateral surface, it is attached to the anterior part of the lateral surface of the medial condyle of the femur. So the function is also opposite of the ACL, that is, it prevents the posterior displacement of the tibia on femur. That is the function of the PCL. Now there are other associated structure. One is the medial collateral ligament, which support the medial side, and there is lateral collateral ligament which supports the lateral side. Now we will go through the kinematics, the different movements in the knee joint, and kinematics again can be classified into two categories. The first one is an arthrokinematics and second one is an osteokinematics. Arthrokinematics means what is happening inside the joint, and osteokinematics means once we are seeing the same movement outside the joint. For example, if I am doing an elbow flexion and extension, the osteokinematics means once we are seeing the two bones and how it moves. And arthrokinematics means what is happening inside this elbow joint, what type of movement is there inside the elbow joint, whether it is a roll, whether it is a spin, whether it is a glide. So we will go through the kinematics of the knee joint now. We discussed that the knee joint is having three types of movements. The first one is a flexion extension, the second one is a medial rotation, lateral rotation, a third one that is can be done passively only, that is an abduction and adduction, and a very mild abduction and adduction is there. So we will go through the kinematics of flexion and extension. Anyway, all the movement will be having an axis. Here the axis is the horizontal line passing through the femoral condyle. And this axis keep on changing throughout the range of motion. So axis is the horizontal line passing through the femoral condyle and it shifts throughout the range of motion. Now, we already discussed the articular surface of the femur is large and that of tibia is small. So, the articular surface of the femur is large and tibia is small, and the femur begins to flex on the fixed tibia. Here, for the purpose, our description purpose, we are keeping the tibia fixed and femur moving. Now, the articular surface of the femur is large and that of tibia is small. Femur begins to flex on the tibia. So, fixed tibia, the femur start flexing on the fixed tibia, and consider if it is a pure roll. What will happen? The femur will roll out of tibia. So, the pure roll should not be there in case of flexion and extension. So, what is happening is that up to 25 degree, there will be a posterior roll of the femur on tibia. As the flexion continues, the rolling is accompanied by an anterior glide of the femur and on tibia. So, we are getting a proper flexion there. That is, flexion means a posterior roll and anterior glide. So, extension will be just reversal of the movement, that is an anterior roll and a posterior glide. We will get an extension movement, and the femoral condyle roll anteriorly while simultaneous posterior glide. Now, what is the role of cruciate ligament on flexion and extension? We already discussed the cruciate ligament, the function of the cruciate ligament. What is the function here? The posterior rolling of the femur during the knee flexion causes the rigid ACL to tighten. So, continuous rolling causes an anterior translation force on the femoral condyle and causing an anterior glide. Now, again the PCL, the function will be just opposite. Now, the function of the meniscus on flexion and extension. Everybody know the meniscus is a wedge shape, and because of the wedge shape, the femoral condyle has to roll uphill as the knee flexes. That is, there will be the meniscus can create a force over the femoral condyle and helps to glide. Now, the first motion we discussed, that is flexion and extension. So, flexion and extension consists, it is not a pure roll, it is a roll along with the glide. Now, the second motion is the medial and lateral rotation. In here, the axis is a longitudinal axis running through the medial tibial intercondylar tubercle. And here the movement is that the medial condyle acts as a pivot point. Medial condyle acts as a pivot point, and the lateral condyle moves through a larger arc of motion. First of all, we will discuss the lateral rotation. The medial condyle moves slightly anteriorly. In case of lateral rotation, the medial condyle moves slightly anteriorly. At the same time, the lateral condyle on a fixed medial femoral condyle and the lateral tibial condyle moves a larger distance posteriorly. So, we will get a lateral rotation. That is, the medial condyle of the femur moves slightly anteriorly. At the same time, the lateral condyle moves a larger distance posteriorly. So, the movement we are getting a lateral rotation. At the same time, the medial rotation, for the medial rotation, just opposite movement, that is, the medial condyle is a pivot point. So, the medial condyle moves slightly posteriorly. At the same time, the lateral condyle goes into a larger anterior displacement. So, lateral tibial condyle, it moves large distance anteriorly, and we will get a medial rotation movement. And all this for all this movement, meniscus follows all these rotation movement. Now, we will go through the different muscles which causes the movement. So, I told you there are muscles, there are different movements. The first one is knee flexion, knee extension. We'll go through which are the knee extensors or extensor muscles. Knee extensor muscle, we can call it is a group of muscle and it is called as quadriceps group of muscles. The main function of the quadriceps group is extension of the knee, and it is located on the anterior side of the anterior compartment of the thigh. So rectus femoris, as the name implies, it's having 4 parts, or it contains 4 types of muscle. The first one is the rectus femoris, second one is vastus lateralis, the third one is vastus medialis, and the fourth one is vastus intermedius. These are the 4 muscles which consist of the quadriceps group, and this causes the extension of the knee joint. Now, vastus among this, the rectus femoris and vastus intermedius is exactly at the center. At the same time, vastus lateralis and vastus medialis on the medial and lateral side. So, the medialis pulls medially and the lateralis pulls laterally, and rectus femoris and vastus intermedius pulls upwards. So, we will get a net force which is 55 degree posteriorly. So, then net force, and this is the one force which keeps the patella in position. So, again the vastus medialis, it's having, this muscle is having 2 parts, a vastus medialis oblique and vastus medialis longitudinal. Now, the vastus medialis, the upper side of the vastus medialis muscle is straight. So, this area is called vastus medialis longitudinal, and the lower side is the vastus medialis is oblique. This is called vastus medialis oblique or VMO, and VMO is having a the main function of the VMO is to keep the patella in proper position and avoid the patellar dislocation. And in case of there are some cases, in case of any weakness of this vastus medialis oblique causes the lateral displacement, and there is an increased chance of lateral displacement and lateral dislocation of the patella. Now, one of the main extensor of the knee joint is the quadriceps muscles, and sometimes there will be some conditions where we have to strengthen the quadriceps muscles. There are lots of methods. There are lots of methods used by the trainers and physios to strengthen the quadriceps muscles. So, we will just go through some of the important methods usually used by the trainers and physios. The first method is the static inner quadriceps contraction. It's a static type of contraction. That is, here what we are doing is that we will keep a towel down to the knee joint or below the knee joint. We are asking the person, without moving the knee, we are asking the person to tighten the muscle, to tighten the quadriceps muscle, or to tighten the muscles of the front of the knee. That is the one method. Another method, quadriceps can be strengthened by using fulcrum, that is quadriceps over the fulcrum. We are asking the subject, this begins with we are asking the subject to lie down, and we are keeping a rolled towel or a form of a rolled towel below the knee joint, and we are asking the subject slowly straighten the knee as far as possible and ask him to tighten the muscles in front of the thigh or the quadriceps muscles. Another method of the strengthening of the quadriceps muscle is by using TheraBand or resistance band. That is one of the most commonly used method now. The subject will be sitting, subject will be in sitting position, and we are keeping the TheraBand from the angle, and we are tying on the posterior side, tying the TheraBand on the posterior side, and we are asking the subject to extend his knee against the resistance of the TheraBand, and like that, and slowly return to the normal position. Again we are asking to lift the leg and again return to the normal position, and with the resistance of the TheraBand we can strengthen the quadriceps muscle. Next method by the squatting, that is squatting methods, and it is by we can use a Swiss ball to keep the knee and keep the back in proper position. That is, the squatting method is the next method by using Swiss ball. And there are other techniques also to improve the strength of the, there are by using weight, squatting method, there are quadriceps tables are available. There are different types of methods commonly used by the trainers and physio to improve the strength of the quadriceps muscle. And next is the quadriceps stretching methods. Everybody will be knowing stretching is an important part of the warm-up protocol, because proper stretching or proper warm-up will reduce the injury, and if the muscles having enough flexibility, it will decrease the chance of injuries. So there are different methods used by the trainers. You can see in the picture, there are different methods used by self-stretching methods, and self-stretching methods can be seen in the picture. These are the different methods to improve the flexibility of the quadriceps muscle. These are the stretching methods. These are now what we discussed is that the muscles of the anterior side of the knee, and they are the muscles that is quadriceps, and the main function of those muscles are knee extension. Now the second group of muscles which is seen on the posterior side of the knee joint, that is called knee flexor muscles. Together there are three muscles are there on the posterior side of the knee joint. This together called an hamstring group. It is located on the posterior side. It contains three muscles. The names of the muscles are semitendinosus, semimembranosus, and biceps femoris. Along with that, flexion is having this muscles are having, these are the rotators of the knee joint also. Semitendinosus and semimembranosus, along with the flexion, it does the internal rotation, because as it is on the medial side of the knee joint, and biceps femoris, which is situated on the lateral side, it does an external rotation movement along with the flexion. And popliteus also assists the hamstring in knee internal rotation. Now, most of the researchers are saying that the hamstring muscles are the most commonly injured muscle or strained muscle among the at different games and different matches, hamstring muscle. So the stretching and proper flexibility of the hamstring muscle is very important in case of an athlete, or the methods of the stretching should be known to everybody, including the coaches, including the players, including the physios and trainers. So these are some self-stretching techniques of the hamstring muscles. So it improves the flexibility and decreases the chances of hamstring strain and hamstring injuries. These are some more methods are there. These are some self-stretching methods to improve the hamstring flexibility. So we were discussing about the tibiofemoral joint here. The second joint inside the knee is the patellofemoral joint. Patellofemoral joint is the joint formed between the patella and the femur. The patella, everybody knows that patella is a sesamoid bone. That is the bone seen inside the bone seen along with the tendon or along with the muscles. So patella, first of all, there is quadriceps muscle, and it is attached to the upper side of the patella and through the quadriceps tendon, and there is starting of the patella, and patella is a triangular shape of bone, an inverted triangle, and from the lower side of the patella there is another ligament, or actually we can say it as a part of quadriceps muscle, and it is known as patellar ligament. And you can see in this picture, you can see the articular facet of the patella in the femur and the articular facet of the patella here. Now, the articular facet for the patella in the femur is triangular shape. You can see it's having the medial and lateral lips and a central groove. At the same time, the posterior surface of the patella, it's having again three parts, three facets, a lateral facet, a medial facet, and an odd facet, and a vertical ridge which divide the medial and lateral facet, and this part is covered by an articular cartilage, which improves the shock absorbing power of the patellofemoral joint. And the function of the patella. The main function of the patella, it works as an anatomical pulley. That is, it deflects the force, the action line of the quadriceps femoris muscle, and in some cases, once the patella is removed, or in case of patelectomy, the person cannot extend the knee joint fully, and that condition is called quadriceps lag. Now, we discussed in previous slides regarding the position. There is an physiological valgus is there in the knee joint. So, because of the physiological valgus, the upper side of the patella is pulled by the quadriceps muscle, lower side of the patella is pulled by the ligamentum patellae or patellar ligament, and because of the obliquity or physiological valgus, there is a chance of a pull of the quadriceps towards the lateral side. There is a slight angulation, and there is chance of pull of the the patella towards the lateral side. So, mainly the vastus medialis oblique muscle is the main muscle which decrease the chance of dislocation or decrease the lateral pull, and so the VMO, once there is any weakness of the VMO, causes the lateral dislocation. Next is patellofemoral tracking. Patellofemoral tracking means it is the movement of the patella during flexion and extension. During extension, the position of the patella is just in front of the femoral condyle. Just in front of the femoral condyle, and the patella moves. Then once there is flexion, patella moves downwards, and the movement is called flexion of the patella. So, as we discussed earlier, the knee joint is a two distinct type of joint in a single joint capsule. The first one is, we discussed already, that is tibiofemoral joint. That is two tibiofemoral joint, we already discussed. And the second type of joint is the patellofemoral joint. That is the joint which is formed between patella and femur. Patella is a bone, it is a sesamoid bone. The shape of the patella is triangular shape, and it is attached to the quadriceps muscle. The quadriceps muscle, it's a four muscles together and makes the tendon called quadriceps tendon. And the quadriceps tendon is attached to the patella, and then the lower side of the patella, then it is continue as patellar ligament or ligamentum patellae, and later the patellar ligament or ligamentum patellae attached to the tibial tuberosity. Now, patella is a triangular bone, and the shape of the patella is an inverted triangle. So, patellofemoral joint, there is an articulation in the femur, and there is articulation on the posterior side of the patella. The femoral articulation is exactly triangular shape. It's having a medial surface, a lateral surface, a medial lip, lateral lip, and in between these two medial and lateral surface, there is a central groove. At the same time, the patella is an inverted triangle. The shape of the patella is an inverted triangle. It's having three facets. That is, the posterior side is having three facets, a medial facet, a lateral facet, and an extreme to the medial facet, there is a facet called odd facet. The medial facet and the lateral facet is divided or separated by a ridge called vertical ridge. And the posterior surface, between these two surfaces, there is a articular cartilage which decreases the shock, or which is having a shock absorption power for the movement. Now, the main function of the patella is it works as an anatomical pulley. What is anatomical pulley? You might have studied in previous classes. And the main function of this anatomical pulley is deflect the action line. So that's why at the end range of motion, because of the presence of the patella, the knee can extend it at the end range of the motion only because of the presence of patella as it works as anatomical pulley. So once there is, in case of any injuries to the patella, sometimes the patella has to be, in certain conditions, the patella has to be removed. This is called patellectomy. Once patellectomy is done, these people cannot extend the patella, cannot extend the knee at the end range of motion. This condition is called extension lag. Now, we discussed in the previous slides regarding the physiological valgus. Physiological valgus means, of the knee means, physiological valgus means, we discussed there is an angle formed between the femur and the tibia. It's a normal angle, it is usually 180 to 185 degrees. Because of the physiological valgus, the patella is having a tendency to move towards the lateral side. So, there are lots of structures which keep the patella in position. The first is the quadriceps muscle itself. We discussed in the previous slides. The quadriceps muscle, the four parts of the quadriceps muscle, one pull towards the lateral side, one pull towards the medial side, and the other one, rectus femoris and vastus indus medius, pulls towards the upward, and we'll get a resultant posterior pull. The another muscle along with the quadriceps, VMO, vastus medialis oblique, it is exactly pull the patella towards the medial side. So, because of this pull, patella is there is lateral dislocation of the patella is not there only because of the pull of this vastus medialis obliquus muscle, especially vastus medialis obliquus muscle. And once there is any injury, once there is any weakness of the vastus medialis obliquus muscle, there is more chance of a lateral dislocation of the patella, mainly because of the lateral pull along with the physiological valgus of the knee. Now, patellofemoral tracking. So, during the flexion and extension movement of the knee, the patella also goes on moving. So, at the extended position, the patella is just in front of the knee. Now, once it goes into flexion of the knee, patella also moving down, and the tip of the patella, once there is complete flexion of the knee, the tip of the patella points posteriorly, and this movement is called patellar flexion. And once the extension movement of the knee, the patella comes back to the original position, and this is known as patellar extension. Now, we'll go through the different structures which gives the patella in position or stabilize the patella. So, the first thing is that everybody know the pull of the quadriceps muscles, that is an overall pull of the quadriceps muscle. The second is especially vastus medialis obliquus, which is a part of the quadriceps muscle, and IT band, we studied IT band on the lateral side, it pulls the patella on the lateral side, and there is patellar ligament force or patellar ligament or ligamentum patellae, which pulls the patella downward. So, all these movements stabilizes the patella and keep the patella in proper position, and any changes in the movement causes an abnormal movement of the patella, and this causes later leads to, and the path taken, patella always move in an S-shaped pattern of movement, and that track will change, and it causes lots of issues, like there may be a chance of patellofemoral pain, a chondromalacia patella, degenerative changes in the patella, a subluxation of patella, or even dislocation of the patella. So, because of this abnormal tracking of the patella. Now, another important thing in the patella is the Q angle. Q angle can be Q angle is the angle between there are once we connect the 3 points, we will get the Q angle. The first one is ASIS, that is anterior superior iliac spine. We will draw the second point is the mid part of the mid patella, and the third point is the tibial tubercle. We are drawing the first line between ASIS, that is anterior superior iliac spine, to the mid patella. The first line is between ASIS to the mid patella. And the second line, we are drawing an extension line, that is starting from the tibial tubercle, and it is an extension line through the mid patella. So this extension line through the mid patella and the line between anterior superior iliac spine creates an angle, and this angle is called Q angle. Q angle is very important in case of different injuries and different biomechanical abnormalities. Finding out the Q angle and is very important in case of different biomechanical abnormalities of the knee. Higher the Q angle generally predispose the people in varying degrees to a variety of potential knee problems, including lateral patellar subluxation, dislocation, patellar compression syndrome, chondromalacia patella, and ligamentous injuries, etc. Now, before we conclude this lecture, especially for the sports trainers, an important injury of the knee is the jumper's knee itself. That is, it is usually seen in runners and jumpers. As we discussed, the patella is attached to the quadriceps muscle through two different tendons. The first one is a quadriceps tendon up and a patellar tendon down. The inflammation of this patellar tendon, especially the lower side, the patellar tendon or patellar ligament, is known as jumper's knee. So it usually affects the inferior fold. 65% of the condition, there is inflammation of the tendon on the inferior fold, and the remaining 35 on the superior fold, and this condition is called patellar tendinitis or jumper's knee. Good morning, everybody. Today we will be going through the biomechanics and kinesiology of the knee joint. Biomechanics, everybody will be knowing, biomechanics consists of two things. The first one is a kinetics and the second one is kinematics. Kinematics means the movement occurring in a joint, and kinetics means the causes of the movement. The movement can be caused by an outside force and an internal force. So any movement in the knee also can be caused by an external force or an internal force. An external force can be given either through manually or mechanically by the outside force or a passive movement, or by using any mechanical devices. An internal force is especially done by the muscles. So today we will go through the kinetics and kinematics of the knee joint, that is the movement occurring in the joint, and the causes of the movement, that is kinetics of the movement, that is kinetics of the knee joint, that is the causes of the movement, that is the different muscles which causes the movement, etc. Everybody will be knowing regarding the knee joint, it is the one of the weight bearing joint, it is the one of the most weight bearing joint, and it is the one of the largest joint complex of the body. All the joint is having two functions, especially the first one is a joint is having mobility function, and the second function is the stability. So usually these are two different terms. We can say these are two opposite terms. Actually, once there is mobility, there will be less stability, and once there is more stability, there will be less mobility, and these are two opposite terms. So for example, we will take the example of a shoulder. Shoulder is a joint is having lots of mobility. So at the same time, shoulder is a joint is having less stability. Another example we can take hip joint. Hip joint is a joint having less mobility, at the same time it's having more stability when compared to the shoulder joint. So the joint will be having usually two functions. The first one is stability function and the second one is a mobility function. Now, but the knee joint is a joint is having both stability and mobility function. It's a mobile joint, it's a stable joint also. Now regarding the knee joint is a two distinct it's a joint where two distinct articulations are inside a single joint. The articulations are, there are again three joints are there inside the joint, inside the knee joint capsule. That is two tibiofemoral joint, that is the joint between the tibia and femur, and one patellofemoral joint, that is the joint between the femur and the patella. So the joints are the tibiofemoral joint, two tibiofemoral joints and one patellofemoral joint inside a single joint capsule makes the knee joint. Now we will go through the tibiofemoral joint. It's a double condyloid joint with 3 degrees of freedom. Degree of freedom means in how many planes a joint can be moved. 3 degrees of freedom means in 3 planes the joint can be moved. The movements available, 3 different types of movements are available. That is flexion, extension in one plane, the plane is sagittal plane. Second one is medial and lateral rotation, that is in the transverse plane, and abduction and adduction in the frontal plane. But some of the researchers or some of the authors are saying the knee joint is having 2 degrees of freedom. The main difference is that abduction and adduction is the movement is very less and it cannot be done passively. It cannot be done actively, it can be done passively only. So we will go through each movement again. The first movement is available is the flexion and extension. Flexion and extension movement everybody will be knowing. It is the flexion and extension movement will be available in the sagittal plane, and the second movement is the medial and lateral rotation. It is available in the transverse plane, and the third type of movement is the abduction and adduction. Abduction and adduction is done, can be done passively only, it cannot be done actively, and this movement will get, once there is injury to the medial and lateral structures, especially the collateral ligament, there will be more chance of more increased abduction and adduction will be available in the knee joint.
In this session, we are going to discuss about the exercise and environment. Especially, we will be discussing regarding the thermoregulations of the body, how the body regulates the temperature. There are certain factors which contribute to the heat gain and heat loss. There are certain activities which increase the heat gain of the body, and there are certain activities which causes heat loss. Heat gain, it depends upon BMR, basic metabolic rate. It depends upon the muscular activity. If BMR increases, heat gain increases. If the muscular activity increases, it also causes an increase in the heat gain. Then hormones are there which influence the heat and temperature. Dietary induced thermogenesis and postural and environmental factors are also influence how much body heat is there, or how much influence of body heat is there. Now, heat loss is, there are 4 methods of heat loss. It includes radiation, conduction, convection and evaporation. Now, the temperature we already discussed once we were discussing about the central nervous system regarding the regulation of temperature. Regulation of temperature is mainly done by hypothalamus. That is, if the body is stimulated by cold, if there is an increased cold, the hypothalamus does the reaction, that is there will be a vasoconstriction. So, once there is vasoconstriction, so it causes a decrease in the heat loss, and in order to increase the heat production, there will be shivering of the body. So, once it is stimulated by cold, there will be vasoconstriction and shivering. Vasoconstriction helps to decrease the loss of heat, and shivering increases the heat production. Now, if there is if it is stimulated by heat, if the body is stimulated by heat, there will be vasodilatation will be there. That is, it causes an increase in the heat loss, and it decreased the muscle tone and voluntary activity will be there. It also decreases the heat production. So, heat decreases the hypothalamus causes an increase in the heat loss and decrease the heat production. This once there is a stimulated, once the body is stimulated by heat. Now, what are the adaptive changes in heat tolerance, that is to improve the heat tolerance? This is called heat acclimatization. That is, once there is an increased heat, the body has to use to make some adaptive changes. This is called heat acclimatization. So, the first thing the body does is that there is an increased cutaneous blood flow. So, because of this increased cutaneous blood flow, it transports the metabolic heat from deep tissue to the body shells. The second thing the body has to do, the physiological adaptive change, is that the effective distribution of cardiac output, that is appropriate circulation to the skin and muscles to meet the demand of metabolism and thermoregulation. The lowered threshold for the start of sweating. So, there will be the next change is, next physiological adaptation is lowered threshold for start of sweating. This is called, these all things are called heat acclimatization. That is, the third one is the lowered threshold for the start of sweating, so that evaporative cooling can begin in the early exercise. So, there will be start of sweating will be early, the sweating will be early, and there will be an evaporative cooling can be begin at the early in the exercise, and more effective distribution of sweat all over the skin surface. So, there is an optimum use of effective surface for evaporative cooling. So, that all over distribution, sweat will be distributed all over the skin. So, this also decreases the temperature, and this is an adaptive change. And increased sweat output, and that is maximum evaporative cooling, there will be an increased sweat output. Then even if there is sweat output also, the salt concentration will be lowered. That is, otherwise in order to prevent the extracellular fluid, that is in order to preserve the electrolytes in extracellular fluid. So, heat acclimatization means these are some physiological adaptations made by the body to improve heat tolerance. It includes, the first one is an increased cutaneous blood flow, that the temperature will be distributed, and effective distribution of cardiac output. Then the third is a lowered threshold for the start of sweating. As there is lowered threshold for the start of sweating, so there will be chance of evaporative cooling begins in the early of the exercises. So, it will come down, the temperature will come down, then and there will be more effective, once it is the sweating starts, it will be distributed all over the skin. So, it will help for an appropriate cooling effect, an appropriate cooling, and increased sweat output. This maximize the evaporative cooling. And the last one is the lowered salt concentration. If there is an excess sweat output is there, but there is more chance of electrolyte comes out, but in this the hypothalamus controls the electrolyte, decrease the electrolyte output, so that the electrolyte preserve the electrolyte concentration in the extracellular fluid, so that the muscle cramps does not occur. Thank you.